Good afternoon. My name is Anthony Borelli. I manage the product and the marketing team for FUJIFILM. And just first and foremost, congratulations, Dr. Hawes, Dr. V, the entire Orlando Health team. This is impressive and not surprising on how you all execute and show what a conference is supposed to be. At FUJIFILM, our slogan, our tagline is value from innovation, and it's something that we take incredible pride and passion in. Over the last 5 years, we've introduced 30 plus new technologies for the endoscopy space, many of those differentiated to help you perform GI procedures more effectively, more efficiently. That pride and that passion, there is a commitment to continue to bring differentiated technologies to you all. So thank you for the opportunity. As we look to the symposium on the evolution of EUS, from a practice standpoint, from a clinical standpoint, we have two fantastic speakers for you. Dr. Neil Sharma is going to be presenting on EUS from an ASC standpoint. Dr. Sharma is from Banner Health. He's the Senior Director of the Digestive Health Service Line and Chief of GI. And then to close us out, Dr. Shyam Tucker is going to be talking about new evolutions in EUS from a clinical standpoint. Dr. Tucker is coming to us from West Virginia University, and there he is a professor of medicine. He's also the director of advanced therapeutic endoscopy. So with that, Dr. Sharma.
Okay. A big thank you to Anthony and FUJIFILM for sponsoring this lunch event. I also want to thank Dr. Hawes for having me back again this year, and V, his whole crew, just absolutely outstanding. They're, like many of you, I grew up admiring Dr. Hawes and the work that he has done for our field of endoscopic ultrasound. And I think the bar is always set very high. Whether this is your first EUS Live or you're coming back recurrently, I think we have a sense of community. So when I get to spend time with all of you who are at very different levels in your EUS journey, I think it's a pleasure for me to be part of this whole community. So thank you for being here, and thank you to our hosts. So with that, thank you. I got asked to speak on a difficult topic, which is performing outpatient EUS in the ambulatory setting. Is it a worthwhile endeavor? So as I started to research about this topic and thought about what it is that I'm hoping to answer for you, I came with a lot of curiosity and hopefully some open-mindedness. And as I found myself working on some of the details for this, I found my opinion to change about this subject significantly. So hopefully as you listen to this, you'll find some practical takeaway values, and you may see some future inroads for application of this technology to a larger cohort of patients. So a little background. This is extremely important for those from the United States. There have been recent changes in the CMS policy. This is just happening in the past 3 months. And what has happened in specific with some of the passage of the new big bill and things specific to CMS policy, they've now changed what is thought to be allowed in an outpatient prospective payment system for ASCs. This affects multiple surgical fields. So for example, orthopedic surgery, a lot of things that were happening in the hospital now are allowed to happen outside the hospital. This also affects cardiology and of course, endoscopy. So this is a big deal. I think what this will lead to later on is a reduction of out-of-pocket costs for Medicare beneficiaries. So what this will mean is that Medicare used to regulate and say, we'll only pay for things in the hospital. I think in the future, things that are done in the hospital are now thought to be safe and then potentially could be offered in an outpatient setting, which will force us to think about what do we really need to do in the hospital, and is it worth the additional amount of expense to the patient? It also increases hospital accountability and transparency. It safeguards us in the Medicare Trust Fund from waste and abuse, because as you know, anything we do in the hospital comes with a big charge to the patient and to the healthcare system, which perhaps is unsustainable in the future. So as you think through this talk, I want you to think about these potential passages of these laws and how they affect things. In specific, EUS, ERCP, and endobariatrics, as well as other endoscopy procedures, have been included in this bill. So they are specifically calling out these types of procedures. So what does this mean for patients, and what are the potential implications for practice of endoscopic ultrasound, and now in the ASC? This certainly changed my mind when I approached this topic. Coming from Indiana, where how I was trained on EUS, it always happened in a hospital-based setting, typically a tertiary setting, but this may change in the future. So the first question I ask, and again, this may be my own bias through Indiana, is this safe, right? Is this something that we can safely do in an ASC setting for patients? Because no matter what the cost efficacy is, we wouldn't do it if it's not the safest thing for our patients. And so there is some literature on this, and I will continue to look at literature, think about the quality of the literature when I make decisions for our patients. So the first studies actually go back to 2014. These are retrospective studies. These are published studies. You can see the authors below. This was first shown at ACG. So they took a look at a cohort of about 885 procedures, so pretty large volume. They're all done with propofol. You can see the ASA grade is 3 or less, 2 experienced fellowship-trained endosonographers, and you can see the major adverse events requiring hospitalization. And they compared those to the same cohort of patients, so same population, getting colonoscopy, and they found that the time satisfaction required to do an EUS, as well as the outcomes for these procedures and patient satisfaction scores were the same. This was retrospective study, but nonetheless, it was a meaningful first step into this arena. 2016, there's now a prospective multi-center study. This looked at the feasibility of both ERCP and EUS in an ambulatory care setting. It was all data collected and then looked at all the way to 2 years out. 375 patients. They were divided between inpatient and ASC and put into 2 different arms. And what was interesting is these patients were sicker than usual. So they had a higher ASA score and they had other comorbidities as well. And you can see how many of them were divided into the ERCP and the EUS arm, with the EUS arm having 277 patients. And when you take a look at this, what they found is for adverse events in EUS, there was no increased or elevated risk. And in specific, they called it a 3% risk of bleeding, pancreatitis and 1% of bleeding. So now you have some prospective data that says that maybe you can do this safely in an ASC. And this is quite some time back without the advent perhaps of FNB and some new needles. Then we specifically looked at liver biopsy. So I like this. This is much more recent data, 86 patients. Again, retrospective review of prospectively collected data. And they looked at, can we do an EUS liver biopsy on these patients? This happened to be the same cohort of people who looked back in 2014 on just EUS alone. And again, they found that it was safe, feasible, and comparable to what they were experiencing in the same patient population when they did this in an inpatient setting. So safety seems to be okay when I summarize all of this. So what is safe? Diagnostics are safe. So you notice we mentioned FNA. Those included FNA in both of those studies. And now FNB, specifically for liver biopsy. They used propofol for all these patients. It is, like most things, operator dependent, so these are all experienced endosonographers. What they did not address are some of the things you're seeing today. So these are therapeutics, specifically drainage-based procedures. And I think one thing that we can always think about is don't be a cowboy. So what does that mean? If you're doing drainage-based procedures, it's not just you doing the procedure safely, but it's also all the other people around you. So if you get into bleeding, you need to go for an urgent or emergent operation, you need to be in a setting where you have those other things to support you. But keep in mind, as was pointed out to me by actually some orthopedic colleagues and cardiology colleagues who I talked to about this, they're doing now EP procedures in ASC settings. So the things that we think of as safe or unsafe, they look at us and kind of laugh at it a little bit. So it is something that we need to consider as we move forward. So then the next issue in the United States is cost and reimbursement. Can you do this sustainably? Is this something that you could potentially sustain the ASC or your practice around? So this gets a little bit more tricky. Again, if you look at the one study in ACG, that was the same study, same cohort, different population. And what they did was they looked at what is the profit. So if you look at the Medicare cost savings, there's actually a cost savings to Medicare. So if you tie it back to the passage of the new bill, Medicare is saving money if you do this on Medicare-based patients. And this is about the net profit that they calculated in 2014. What's surprising is things have changed. You actually are getting a better reimbursement for the facility fee and the physician fees. So let me take you through a little economics or how we would look at this interplay. First, you need capital. So here's the capital costs for different manufacturers, Olympus, Fuji, Pentax. And down below what you're seeing is a newer technology called endoprosound. So endoprosound is something that actually fixes onto your regular upper endoscope and allows you to perform linear array endosonography. It has a Medicare traditional pass-through code. And that code allows you to actually even engage commercial payers, and most commercial payers pay for this. So that cost actually is even significantly lower. You don't necessarily need a high-end processor. So if you look at a Fuji processor, this is the listed retail amount. You can use the entry-level processor and perform all of these procedures potentially in ASC. Again, endoprosound is even less expensive than that, but it only attaches in a linear array transducer, not a radial. So then here's the needle costs, because you need to factor that in. F&A, F&B, these are, again, retail costs. These prices can be lower. Usually they're not going to be higher, but they may be lower depending on your overall purchasing agreements with these individual companies. And then specifically for endoprosound, they're microtech needles that have reduced length so you can pass them through an upper endoscope, and you can see what the needle costs are there as well. So then it comes down to essentially a math equation, right? So this is what you get paid when you do the procedure. What this is the most of the latest 2025 facility fee, and then there's also a payment to the physician as well for the procedure. So you can see this being called out. So the ASC fee, as you can see right now, is significantly less than if you do the same procedure for the same patient in the hospital. But I think the purpose of the new bill is to try to start to equilibrate some of these costs to Medicare so that the system itself can be sustainable. So what do the economics look like? And just from my background in doing a lot of healthcare administration, if you took at this, I look at what are fixed costs. Fixed costs are the cost of the capital investment, as well as overhead from your facility. So if you're doing an ASC, you're gonna have anesthesia, you're gonna have staff, you're gonna be paying rent on that facility. Then if you look at a per care cost, you use Medicare numbers, so I just gave you Medicare numbers. The facility fee has gone up to $864, plus the physician gets paid $251. So that's the total amount of money that you're gonna take in. You then subtract the needle costs that I gave you, plus the fixed costs that I outlined above. You also will get some pathology reimbursement. So this is something that I looked into also for this talk. If you do rapid onsite, which you can do, before we didn't do it, but there are some centers that actually the pathologist is employed through the GI group. They can sit there by the ASC, they can come in and give you rapid onsite. You can bill cytology charge for the rapid onsite, and then you put the rest in formalin and you bill a surgical charge like you would for forceps. If you don't have rapid onsite, you would do an F&B only and you would bill just a surgical charge. So you put all this together and you have your facility plus your physician payments, you have your needle and fixed costs, and then you also get some money back for pathology if you have that in your facility. And here you can see rough ballparks of what all of this would look like. You obviously can depreciate the equipment over a period of time. You could rent the equipment, so you don't necessarily have to come out of pocket for those costs. This probably makes it much more economically sustainable than even 2014. A little bit on pathology. So this actually changed my mind as well. I'm a big believer in rapid onsite. Everywhere I've been has had rapid onsite. But the world has changed a little bit, right? So for solid lesions, maybe it's a disadvantage if you don't have a rose, but for now, we know that you can get an 89 to 94% yield doing 2 to 3 passes with a fork tip or Francine needle. This is published data, everyone can do this. So you don't necessarily have to have rose. Cystic lesions, it's just sending fluid to the labs. You could do pancreatic cysts in your ASC as well. A little bit about the advantage of the ASC. So similar time to colonoscopy, 30 to 45-minute blocks, unless you're Anand Sahai, who yesterday said he can do this much faster. Physician time, so no need to drive to the hospital. It can be worked into the rest of your cases. Remember, when you're working in a hospital, you get bumped, especially if you go after hours. You're fighting for block time, and there's inherent inefficiencies. What about future direction? So where do we go with this? So I think first and foremost, let's override the new law and the new things passed by Medicare and think about the future state for this. The future state may be that payers now are going to follow Medicare like they always have in the past. Medicare may be more receptive to thinking about doing these procedures in the ASC. They may actually be able to negotiate with these payers. So a private payer will say, now we know it's safe, Medicare has allowed for this, and we're going to pay X amount to the hospital. You can negotiate with them perhaps and say, look, we'll do this for 2/3 of the price of the hospital. And you can start to do this safely, which we know. And these are the lesions that I may select. Subepithelial lesions, EUS liver biopsy, all sorts of masses that don't require fiducials, because if you look at fiducial costs, it's quite expensive, and pancreatic cysts. I think things like therapeutic drainage procedures probably are off limits, right, for now at least, because of the supportive care needed and the other services you may have to call upon. And some centers can offer rows even if the pathologist is not directly there through either virtual, or they can have the pathologist on site. And increasingly, they're going to start talking about right place for the right patient. And so you're going to hear this in all sorts of health systems. I can tell you we're talking about that in Banner Health already. And what are the win-wins for the patient that make things economically sustainable? So this topic that I was chosen to talk about has really kind of changed my mind and made me think about the equation a little bit differently, and I think that there's a potential future for the role of EUS in the ASC.
Well done. And if we have time, we'll take some questions at the end if we have time. So Shyam, you're up.
Thank you, Rob, and thank you again to you and Shyam and the entire Orlando Health Planning Committee for the opportunity to share with you here today. It's been an honor to be a part of this conference and really great to see all the growth and connect with everyone here. So I'm going to talk to you a little today about the passion we have around the Fuji Echo endoscopes as well as the Arietta 850. Just as some background, as many of you know, the demand for endoscopic ultrasound continues to rise. Market growth is driven by various factors, including rising prevalence of gastrointestinal cancers, technological advances, and increasing incidence of pancreatobiliary malignancies. And certainly the global market continues to grow, and we're hearing a little bit about that now, but in 2024, US dollars, 1.53 billion were spent around the world when it came to spending on endoscopic ultrasound, and expected to reach 2.27 billion US dollars in the billions by 2030. And so when we talk about what all is happening in the market, this market is also being grown by product outlook, by the user outlook, as we heard from Neil, with ambulatory surgery centers now coming into the picture, hospitals, and certainly by the applications with the different various interventions we can do and we've been seeing through the conference, as well as the products, again, with respect to the growing innovations in endoscopes and devices. And so what I thought we would start with is talking about the diagnostics and really the optimized imaging that we're getting with the Arietta 850, specifically detective flow imaging, shear wave measurements, and enhanced resolution. And then talk about also the optimizing therapeutics with respect to interventional EUS. And we've seen many of these procedures already through the course, but I thought we would go into some of the benefits that we have with the 740 UT in order to perform these procedures. So let's start with diagnostics. So detective flow imaging, you heard a little bit about this already, but essentially it's the next generation algorithms, filters that allow us to basically visualize fine vessels with ultra-low velocity and do this without administering contrast. You know, contrast harmonic imaging is really the gold standard when it comes to doing microvascular imaging. But some of the limitations of it is, of course, that it requires a contrast agent, and that contrast agent can certainly have adverse reactions. You know, it takes time for it to be circulate, and then for us to get that imaging, we have to record that imaging in order to confirm that we can then go back and play it, because it only lasts for a little bit of time, a minute at most. And then there's the risk of adverse reaction to that contrast agent. Severe adverse reactions have been well documented in the literature, and even death has been documented in the literature from it. So it needs to be taken quite seriously. DFI offers a similar functionality as contrast harmonic imaging and can allow us to visualize vessels. And so here's just an example of a pancreatic mass where you can see really nice resolution of that mass. And once we've identified it, we of course do the color Doppler, and we can't really get that microvascular imaging, but with DFI, we certainly can see that quite well here. I'm sure you can all appreciate, and in keeping with a pancreatic mass, you know, in general, these are not well vascularized lesions to begin with, and so we see a little less of that. And some of the advantages, of course, when we're dealing that with pancreatic masses, of course, when we do our FNA or FNB, it can help us optimize our target site so that we minimize bleeding, and we can effectively, of course, select that puncture site. And then it can help us differentiate lesions when we're talking about mural nodules and pancreatic cysts, differentiating them from mucin balls as an example, or help us differentiate gallbladder lesions, you know, a cholesterol polyp versus a gallbladder cancer versus just a sludge ball. And so this is a great opportunity for us. And actually, Yamashita and colleagues did a nice study of 53 patients where they looked at using DFI versus E-flow endoscopic ultrasound, and what they were able to demonstrate was that the DFI was significantly better when it came to E-flow as compared to DFI was significantly better as compared to the E-flow. And not only this, but it correlated very well with the contrast-enhanced EUS. So contrast-enhanced EUS was used as the gold standard, of course, in this study. And this was for IPMN-type lesions, gallbladder cancers, or gallbladder polyps. There was no significant correlation, of course, of the E-flow to contrast-enhanced EUS, as we know. And the performance characteristics of DFI were very good as well, with sensitivities of 91%, specificity of 100%, and accuracy of 92% for pancreatic lesions. And so, to summarize kind of the impact that DFI can have, it really offers us capabilities that approach the performance of contrast-enhanced EUS. And again, there's no need to actually give that contrast, which is beneficial to the patient, and then it reduces the time in which we do this all. And here again, you can see in a pancreatic cyst, differentiating this from a mural nodule is quite better when we use that DFI. And so what about additional diagnostics that we get through the Arietta 850? And so shear wave measurement is something I want to spend a little bit of time on. So shear wave measurement is essentially this push pulse that gets put through this region of interest, and it propagates through and measures the stiffness as that wave comes back and propagates back into from the transducer. And so it estimates the stiffness or the hardness of the tissue. And that shear wave measurement, as you can see in the upper right-hand image, can give us kind of a sense of how stiff that tissue is. But there's also this quantity that's the shear wave measurement percentage, the VSN. And so what that tells us is the quality really of those shear wave measurements. And, really want this to be over 50%. In fact, Rob and Cham in their book talk about having that value over 60% to understand the uniformity of that lesion. Well, one thing that we know, though, about pancreatic cancers is that they're not very uniform at all. And so when we perform shear wave measurement with this, what you can see is we may get higher shear wave measurement results, but that VSN is actually very low, suggesting that the quality of that measurement is not very good. And this actually has some implications that I'm gonna tell you about here, that shear wave measurement percentage. One other thing I want to point out, though, is the real-time elastography that can be performed at the same time to assess the stiffness as well. And you can see where the blue areas are is certainly the harder areas of the lesion, and you can use that to help also target when you perform the biopsy. And here again, you can see really the outstanding resolution when we perform that. But getting back now to that shear wave measurement percentage, this was a nice study done by Takeo's group that they looked at that shear wave measurement percentage to assess pancreatic lesions. And what they were able to demonstrate was that the shear wave measurement percentage of pancreatic cancers in general is very low consistently. And this may be a way to help us also characterize lesions. When they compared this to the background area of where the pancreatic cancer was or to normal pancreas, you can see uniformly the quality of those images was coming back very high. The quality of the shear wave measurements essentially was coming back very high as compared to a pancreatic cancer. It makes sense, right? Pancreatic mass is essentially something that's shot to heck, to pardon my French, but it's a lesion that may have some necrosis, it may have cystic component, it may have some stiff components. So the quality of that shear wave measurement's not as great. And similarly, they were able to demonstrate this in autoimmune pancreatitis. But what's interesting about this is that when you give treatment for autoimmune pancreatitis with steroids as an example, after 8 to 16 weeks, you see the quality of that shear wave measurement significantly improve, suggesting that we can also use this as a way to follow response to therapy. So I think this is just, this is technology that we're starting to grasp and understand, but it really has a remarkable impact that we could then have that goes beyond imaging, but following lesions and considering, endoscopic or ultrasonographic remission when we look at things like autoimmune pancreatitis or inflammatory conditions, much like the inflammatory bowel disease colleagues do. So just to kind of summarize that, it can certainly improve the accuracy of EUS, FNB or FNA interventions. When we look at lesions, shear wave measurement and percentage are certainly helpful in characterizing lesions. And then again, of course, we can use this to help us manage therapies kind of going forward. And so let's talk now about the therapeutics, because this is when the really more exciting portion of things when it comes to some of the innovations from Fuji, which is the 740 UT Echo Endoscope. This echo endoscope has a lot of new features in it that really, I think, make it a game changer. It has a single crystal transducer for really increased image quality, as you saw in that fine needle biopsy. It has a wider endoscopic view, so you can see more endoscopically as you're performing therapeutics, and it has a wider scanning range for EUS as well. More tip deflection, so that when you're doing things like interventional EUS in the form of a hepatogastroscopy, and I'll show you an example of that, you can really get into a decent angle and still perform interventions without major issues. And then it has a nice working channel size for our therapeutics and a nice G-locking system that allows for a sophisticated and ease exchange. So here you can just see, why is that beneficial? Well, again, smoother device insertion when you have more endoscopic visualization, easier to exchange, better access to target when we have more deflection ability, more device visibility in the endoscopic image as well that I'm going to get into, and also in the EUS scanning portion. And then the quality is, again, improved, as well as improved maneuverability and friendliness with respect to the cord attachments that our techs and nurses always appreciate. But this is what I mean by game changer. So here you can see the lens on the 740 UT, and it's above the working channel. So now we can essentially see everything that we're doing and see the transducer as we're introducing it, as opposed to the traditional echo endoscope where it's beneath the elevator. So there's a portion that's blind whenever we're performing an intervention endoscopically. And so here's just an example. This is also from Takeo's publication, where they essentially, you can see very nicely how we introduce the scope. And here he performs a hepatogastroscopy and is able to get the scope into a decent position and access a B2 duct really without, any major difficulty, and then pass his wire antegrade, as well as access the right hepatic system to ultimately place metal stents to treat this obstructing hilar stricture. And then, of course, can also do this with the size of the channel. There's no issue with passing these delivery systems as well, and then ultimately deploy. And you can see the endoscopic images there briefly for a second, but I'm going to show you that in a little bit more clearness here. So this is a case of a EUS GJ that we were performing, and here, of course, we deploy our distal flange for the axio stent. Once it's deployed, we can then deploy our proximal flange. But as we do this, I want you to notice, commonly everyone's doing this under blindly in the scope. But here we can very clearly see the white and black differential and deploy that proximal flange under endoscopic guidance. And to me, this is just more comfortable to do. I feel like this offers us an opportunity to just be able to very nicely visualize as we perform the intervention. This is just another example of a cystgastrostomy, and in the interest of time, I'll skip it forward just a little bit here. And so you can see the large cyst that once we gain access, again, deploy that distal flange, but as we deploy the proximal flange, you'll see here consistently, we're able to see that proximal area where it needs to deploy. So there's no real hesitation, no concern that I'm going to get caught on the elevator when I'm trying to remove the scope over the stent and try and push it out and turn my body 90 degrees. I don't have to do any of that. I just watch it happen in real time, and it's much less mental workload for me. And so, that becomes a huge advantage as well. Finally, with that 740 UT scope, we get the opportunity to get more vertical. We saw some great cases of tissue sampling yesterday, and in one case by Dr. Rausch, where he had to get very vertical, the EUS 740 UT scope certainly offers you that advantage as well. And here's just an example. This is a case that we did at our first West Virginia Interventional Surgical Endoscopy course. My partner, Dr. Singh, was performing the procedure. You can see Dr. V in the background there. He was doing a choledochoduodenostomy. And this is where something really like this comes into a great advantage. I mean, he's going to perform the choledochoduodenostomy, and unfortunately, as you'll see, he goes to deploy the distal flange, but it deploys outside of the bile duct. And so this is a potential, adverse event that's going to happen. But because of the aid of having that endoscopic view, he's going to be able to salvage this. So initially, that stent is removed, a wire is placed into the biliary tree, and I'm just going to let that show here. And then once the wire is placed, he'll move forward with placing that stent. And it happened pretty quickly there, but you can see, this endoscopic view of as we're deploying it, is very beneficial in a case like this when you need to perform a salvage. So I think you can't express the value in that moment, in that time, to be able to do it, but certainly we found it to be of great value to us. So, just a quick word on the radioscope. This has been another innovation from Fuji, and I think this offers a lot of advantages as well because it's completely forward viewing. So you can go down and assess your submucosal lesions or your esophageal cancer while doing your endoscopic exam at the same time. If you need to perform any intervention like placing a stent, simply place your wire right there through the radioscope and place your stent shortly thereafter. And so to conclude, the B mode resolution, I think, of Arietta 850 provides outstanding clarity and image enhancement. The DFI produces an opportunity for, really microvascular imaging that reduces the need for contrast-enhanced EUS. That's always safer for the patient. Shear wave measurements and shear wave measurement percentage, I think with the Arietta 850 is really useful in characterizing lesions. And I think the more we apply this, the more we're going to learn, the more we're going to be able to follow our lesions and see the treatment impact. And then the use of new EUS scopes allow for the safe and outstanding performance of interventional EUS. And finally, with the growing market, I think the future is really bright, as Neil described as well, with the potential to include artificial intelligence, quality control, and growing therapeutics. So thank you all for the time. And with the growing theme, I'd like to invite you all to our WVU Interventional and Surgical Endoscopy course next May. Thanks.
Thanks very much for both of those talks. We've got a little bit of time, I think, to answer some questions if any of you have them. I just wanted to start with Neil a little bit. You did a great job, I think, of looking at the economics and so forth. But I'm just thinking about some of the nuances of working in an ambulatory care center and doing what I consider sort of complex procedures. Not just EUS, but you talked about ERCP as well. What does that do to the flow? I mean, you got ERCP patients, maybe some EUS patients, you do an FNA and maybe they've got some pain and they have a prolonged recovery time. ASCs are highly efficient. They expect to get patients in and out really, really quickly. Will it disrupt, does adding this technology potentially disrupt the flow of an ASC and make it less efficient?
Yeah, that's a great question. How many people here work in an ASC? Just like by a show of hands, go to ASC at all? So pretty over half maybe or so. Yeah, so I think like if I look at the workplace of these individuals who are here also interested in EUS, I think some procedures would be very, very difficult in making an adequate flow. So like for example, ERCP was mentioned. Obviously the recovery time, there's a little bit unpredictable, that pancreatitis or getting extubated. But it seems like for EUS, when they specifically looked at it versus colonoscopy for diagnostic EUS, they were kind of similar time blocks and able to do that and work it in their workflow efficiently.
The other question I have, and this is just purely just I'm interested in your thoughts. EUS can be done really poorly, and it's one of the things is you can stick the scope down and if you don't spend enough time, you'll miss things. In an ASC, I mean, you've got probably 2 rooms going. You're going in here. Maybe you've got a scribe for your reports and so forth. You go back and forth, and then you have an EUS of a submucosal mass or whatever. Is that environment possible to sort of encourage less quality EUS? You get paid. You look for a couple seconds, you make a report, and maybe you miss things?
Yeah, I mean, I would agree with you in some ways, right? Like I think like in the sense of, for the fellows that I've trained, it probably drives them nuts, but I'm like pretty meticulous about what does the report look like? What have we looked at? Before I go do a gallbladder drainage, I always do a complete biliary exam just because there's other things that pop up. I think when you look at what I talked about, there is 3 components, right? We talked about the regulatory component changing. We talked about the safety, which I think the safety is there. And we talked about the economic sustainability, because you have to have all 3 things. You have to have regulations saying we can do things in the ASC. We have to have safety. That's the paramount thing for the patient. and we need economic sustainability because without a margin, you can't sustain your mission. What I didn't talk about is quality, and I think you're mentioning that very clearly. Quality can be cannibalized in both settings, to be honest, right? So like, I mean, what I always tell people, and it's even sometimes drives some of my partners nuts, but I think at the end of the day, why do we go spend time at tumor board? Why are we methodical in our EUS examination by station? Why are we doing extra checks on things before we perform an intervention? It's because EUS is not intended to be a biopsy or therapy. It's really a thing that we can leverage to look at the entire area in a lot of detail, and there's a lot of unexpected findings. So I would agree quality was not one of the 3 sections, and that could be cannibalized in either the hospital or ASC setting.
Because ASCs, I mean, there's no credentialing in an ASC. I mean, I can go in and
Well, I might disagree with that. Of course, the credentialing privileging is dependent upon the ASC itself, right? But, you know, it's up to us to, you know, in our societies, continue to push forth those minimum credentialing, you know, needs. That being said,
societies can't regulate ASCs. So the ASGE can't say, I mandate that you do, you know, 350 EUSs before you can do EUS in your unit.
No, but they can of course make recommendations, and it's on the ASC, of course, to have that baseline need for privileging, much like for endoscopy and colonoscopy. And I would think the ASC, being very vulnerable, you know, would want to ensure that that's in place, because at the end of the day, a lot of these are, you know, independent ventures or joint ventures that ultimately can be at risk. You know, the other thing I would add is the added efficiency that you get out of the ASC will also play into the physician's ability to probably perform better quality. You know, there's certainly that potential there as well.
Can I just add one thing? So I think having to do this talk, which I was a little surprised about the topic, to be honest with you, if I didn't come in with curiosity, my initial question was always like, why do you want me to talk about this, right? Like, why do you want me to talk about this? And I agree with you on the quality issue being an issue, but I don't know if it's a factor on ASC versus not. And I'll tell you, from our home state, Indiana, Al-Haddad does most of his work out of an ASC for the diagnostic EUS, and does a lot of high quality work. I do agree with you that we have to control for quality. In every setting, ASC maybe being more at risk, but it'd be no different than the hospital. The other question, though, we have to ask is, do we want to gatekeep the technology to where patients don't get access to it, right? And I feel really strongly that that's the wrong way to go in the future, because we want people to be able to learn, that's what you're here for, and to be able to give, because we're here to give to the patients. So I think if we can avoid the gatekeeping and keep the quality, that's probably the right question. How do we do that?
Yeah. I just, you know, I'm at the end of my career, but I just worry about this trend, I think, in all of endoscopy. And I mentioned this during my presidential year for the ASGE many years ago. This inevitable march toward lower reimbursement, you know, lower physician reimbursement always produced higher quantity. And it's hard for me to see how quality even is maintained, let alone be increased in that kind of an environment. And I'm not sending out blame in any way. I worry about this trend, and I think EUS is still, it's a difficult procedure to do good quality. It's not hard to stick a scope down and look around, but it's hard to do a really good examination, and you get in there and you can't figure out what's going on. It takes time to do so, and I just would hate this technology to be carried down that same river of lowering quality, et cetera. So I think, we have a question? Not from Kumbari.
And maybe that's our challenge, you know. In realized terms, colonoscopy reimbursement has dropped 40% in the last 2 decades, right? And so maybe we should think about how can we be more efficient in the colonoscopy, and maybe different technologies to do the same.
Yeah.
Just had a question maybe to the panel about the right in the right location. I think is a wonderful statement. Is there a world where reimbursement is, and the dollars is site agnostic? So what you get paid in a hospital is what you get paid in an ASC. And will that drive us to do the right thing without any sort of financial bias?
Yeah, that's a great question. Vivek, you're always like insightful in thinking about different ways in which we can advance, what we're doing for patients. I can speak to other fields, right? So I try not to live in a vacuum of what GI is living in. So there's a big push from ASTRO, which is the Radiation Oncology Society, to say, hey, like we're charging patients a lot for radiation, which is already cancer, super expensive, and they've been pushing for the past 4 years to get neutral site of service, equal payment. And so there are other sites that are pushing for this very, very rapidly. Radiology is also doing it. Like there's self-standing MRI centers. We pay half the price of going to the hospital. And so for the first time now, I think that we recognize that we're in an unsustainable system when it comes to healthcare economics. Our gross domestic product is increasingly being spent on healthcare. So how are we going to mitigate that? You bring up a really good point, and it's probably happening in other places. And good or bad, I mean, I think that will help. This bill will help in some ways to maybe start to bring that about. And then relative to Rob's point, you get crunched in a fee-for-service model where there's decreasing reimbursements for the work that you do. But if you look at other fields, like law, for example, you're paid by an hourly time, right? Your time spent. And so I think it's on all of us as physicians to just say this is also unsustainable as a physician to be able to be crunched by how much output you do, but what is the time I'm spending to do these things?
All right, good remarks all the way around. I want to thank Fuji and Anthony for supporting this symposium. I want to thank both of our speakers for really, really good talks. And I think we're ready now to begin the afternoon session, so if we can hit the video, then we'll get going.